Bhagavate Ma Shri Aravinda Om Namo Bhagavate Ma Shri Aravinda Ma Shri Aravinda Om Namo Bhagavate Ma Shri Aravinda Om Namo Bhagavate
together and we discussed about it, and it was postponing not to have any conclusion on that. And now somehow from the health sector there are few units executives came together and discussed. We finalized something, but today we want to give that presentation from our community. Is there any suggestion from your side? Is always most welcome to add in this. This is not finalized version. It has to give a suggestion from the community, then only we can finalize. This is from collaboration with the FAMC and Health and Aging Trust. And today the presentation will do Auroville. So he will talk about 5 years with us, and Lakshay will do question and answer session. Thank you all.
Welcome everybody. When this FAMC started now 2.5 years ago, they also took over the BCC. It was an extremely complex construction with more than 110 units supported, presumably, which was of course not done in time. It was actually not possible because how could very few people in the BCC without specific knowledge actually make budget for so many different entities. We have created a system that was actually not manageable. So one of the first things this BCC actually did was then at least to try to club some of them together. The first clubbing was through sector, so actually SAIA becomes the one that holds a new budget because SAIA is the one that has the sector specific knowledge for the education. So the next one we wanted to put together was actually the heads, at least 20 units supported by BCC, which is part of the health system in Auroville. They all come up for historic reasons. I'm not saying they're not doing a good job, but they all have come up for very specific things they do, and they do not collaborate very much. And there's actually a lot of gaps between them. So what we somehow said, we need somebody from the health sector who can help us put this into a system. Also in a collaboration, that each of them learn to collaborate better, and so and also that the resources they get from BCC are spent better. So I think Lakshay and Surya Gandhi from the Health and Healing Trust and Suban, they volunteered to start this process. They have done a huge work also to find out the history of each of these entities, how they came up. So the document they have created, which has been created over quite a number of sessions. This is the first public session. There have been with the health people from the different sectors and from the different units. And they have created a very fine document, I think, which is also tells a history of why all these things came up. There was a reason for it, why these came up. Some of these reasons are not anymore. That, for example, it's obvious that we created a health center in Kulapalyam, which is now outside, and that it's maybe not valid to have it anymore. The main problem is also, for example, the pharmacy still lies out there, which is probably not very practical now for most Aurovillean to go to a pharmacy out there. So there are many things that have to be thought about if it's actually valid as it is now. So I think changes will come, but it should be done together with the people from the sector. But we all know that things will have to change. There's another big challenge that comes to us now is that India is actually moving into India is a socialist state, if you don't know it. And they actually have a kind of willingness to give social security to people. So they are started now with a new social program that actually gives, right now it's all Indians above 70 will now get a 5 lakh health coverage for each year. That means our health fund system will be challenged because Indian Aurovillians will soon say, why should you pay to a health fund which actually covers less than which will be covered by a national system. So there is a lot of changes coming to us we have to think about, and we probably have to adapt our systems to these realities, because you can't just say we continue as we did before, but because it will not be valid. So to do this in a harmonious way, it's important that all the people who are in the health sector collaborate. The team behind it, Lakshay and Surya Gandhi and Urasugan, also saw health a bit more wide than normal. That's why they call it wellness. And I think that's very much in line with Auroville's ideas that we see health not just as a hospital or doctor view, but see it much wider. So you could say what we try to integrate now is not only the traditional health things, which will be Santé or health center and pharmacy and other things, but it actually will be wider. There's no, you could say, we have no, the only agenda we have from FAMC side is actually try to get this system to work better, to be able to face the realities that are coming, and to do it in an efficient way. And you could say, as I think Surya Gandhi also have said before, that it could be easy just to ask the government of India to take over health in Auroville. We don't want that. But in order to stop that, we have to come up with a realistic thing that provides a good health offer or wellness offer for Aurovillians. Then we can do what we want. And then it might be a model for others to duplicate. But right now, the health offer we have is actually faulting in quite many ways. There are many holes in it which is difficult to bridge right now. I don't know if we take questions now or no. Okay. So let's look at it with open eyes. If there's no anybody who wants a specific result, this is basically to create a group that can guide FAMC and BCC in the decisions. Neither FAMC nor BCC have people who have a specific knowledge about health. So it's very difficult for them to take decisions like that. It's actually not possible. They need a guidance for that, for sure.
Yeah, thank you, Torgil and Surya Gandhi. So I'm Auroville. So I came into this as a resource person with my experience in healthcare administration, as well as handling the health sector here for 2 years. I was part of the COVID management task force for the second wave. So based on that experience and what are the gaps that were there in the health sector, so I came forward to help the team with my skills and knowledge to enhance this document. So when we talk about this, it's a document or a roadmap or a framework that we have come up for the health sector. Okay, so it has gone through a very robust process. It's not just three of us did this document. Okay, it went to various steps where we have invited representatives from all the sectors, made a subgroup we had a first 2 days workshop where the team members were there, and we made this document. So once that came up, then we called for a larger health subgroup. We had a meeting at SARE. So again, this was presented, and the feedbacks from that meeting, again, all this important information was incorporated into the document. So now we are at the third and the final phase, where we have called an open call for the community presentation. So here we have the document ready, but as Surya Gandhi was saying, it's not the final document. We are still in the process of fine-tuning it. Because we know in some things, the groups, the document was shared. We have no harm the document being shared, but it is not the final version. Okay, since every day, some new topics or new things are being made to make the document very comprehensive one. So how does this document go next is, so once the document is over, it will be presented or given to the FAMC. From there, it would be going to the governing board, and there happens the decision. So as a resource team, we end with this process where we create the document, hand it over to FMC for the next step process to happen. Okay? So I'll be going through a presentation that actually covers the main aspects of the document. So this is a document that we have come up. The presentation will not have all the text, but it will just have the headings. So at the end of the presentation, if you have any questions or if you have any feedback, we have a long question and answer session to get all your inputs. And all your inputs, I hope, are focused towards this document and towards health sector. So with this, I will go on to the presentation. Yeah, somebody could help me in running the presentation. Yes, sir. Thank you. So yeah, we all know health is a fundamental need, and health is an important aspect of one's life. Okay? And that is where even the sustainable development goals, where health and well-being is the third goal. So it's very important to look into a healthcare system, and especially for Auroville, where we have a diverse group of people, diverse ideas. So it's very important to really look into a holistic approach. So here, that is why we're not calling it only health. As Torgil said, we have expanded to wellness. Okay? So first, yeah, the integrated health and healing ecosystem. So why do we need to come up with this? And are we really focused and aligned to that principles? So the core principles that we took when we created the document is from the books of Sri Aurobindo and Mother, the integral healing. So a lot of references have been taken from that to make this document really applicable for Auroville. So I'll just go through it. So true wellness in Auroville encompasses the well-being of all planes existence described by Sri Aurobindo. So Sri Aurobindo has given these planes, So health is not about only physical health. So he talks about physical, vital, mental, psychic, and spiritual health. So we have tried to encompass all these 5 planes into this document. And we have also tried to incorporate all the 12 characters. So Mother has put the 12 characters for individual development. So we have took all those 12 characters and tried to put it into the framework of the health system. Yeah. So can we go to the next slide, please? Yeah. So why do we need this transformation? So we, from the health sector, have grown organically. Okay? But we need to really focus a little more on a wider concept. The reason why we need to look for this transformation is we have been operating on a siloed operations. So here and there, health sector or health units coming up. We have an administrative or a financial thing that looks after through the Health and Healing Trust. But there is not an overarching body, like what Torgil rightly mentioned. Let's take SARE. We have something very concrete for education. But health is a very important aspect. So do we have one thing as a whole? So that is very important. And we really need to look into the integral system of all this. Are all the health delivering units or service interlinked? Are they with that vision of integral health? So we really have to have this question, which is lacking. And we need to move from a process from curative to proactive wellness. So right now, when we see our health structure, we are more focused on curative aspects. When we have some health problem, we go to the health center or Sante. It's more curative driven, either the health fund. It's also driven by curative. There is no support or mechanism for proactive or preventive care. So we really need to shift, that paradigm shift needs to come from a curative mindset to a proactive mindset. So we also have specialized healthcare. So as I said, the health sector has been organically growing. It has been more individually driven. So I came out from an eye care background, so I took eye care. So Paula came from the maternity and child health. So she has taken that. It has been organically grown. But when we see if there is an overarching thing to really integrate all that, that was missing. So we really need to work on that aspect. And also need to see whether we have aligned with the principles and visions of Auroville. So that is very important. So do we really have a vision for the health and wellness so that all the organizations working under the health sector can really work towards that vision? So in this document, we have come up with a vision framework, which is a very important framework. So that will give that kind of an important direction for all the services or unit that work into the health sector. And the other important aspect that we really need to look into it is integration, as I've been talking about integration, integrating all the systems together. Education. So education is, again, a missing area that we identified in health sector, starting from schools, adolescent health, okay, maternity health, women health. So it has been happening, but in the education part, there has been a gap, okay? And also about the collaboration. So when we say about internal collaboration as well as external collaboration is very important. We see the health sector. The health sector outside has grown bigger and larger than the healthcare system in Auroville. So when I hold a strong relationship with the health sector because I was born in Auroville Health Center. 1986. Okay, we had a maternity, we had a childbirth center. I was born in Auroville Health Center. I had my immunizations happening in the health center. But now if I see Auroville health sector, when I compare it with the outside health sector, if you see all the villages, you have primary center, secondary center. So it has grown to that level. So when we need, for Auroville, we don't need such a kind of a big healthcare system, but we really need to have collaborative approach so that we can work together. And sustainability. So when we talk about sustainability, I'm talking about financial as well as also the environmental, social sustainability part of it. As Torgil said, 20 units need support from BCC because health is cannot be an income generating part. It needs to be supported. It is an unit that we need more financial things for the equipment, infrastructure, all that. So we really need to look about this sustainability part when we go forward with the wellness thing. Yes, next slide, please. So here we come up with the vision statement. I will read it. So the vision statement for the wellness thing is to establish a well-rounded care ecosystem in Auroville, harmonizing physical health with mental, emotional, and spiritual growth, which can eventually become a global model for integral wellness. So in this vision statement, we really look Auroville wellness plan to become a model for a global level. So we have that kind of a capacity, or we have that kind of a diversification to give a global model as a learning experience for the outside world. So now if you see the outside world, it's more commercial, it's more curative, but we can change that kind of a model. Yeah. So next. So these are the core principles that will be focused for all the units or services that would like to come under the health Auroville wellness thing. First, alignment, I'll not go into details. Alignment with the Auroville principles. Okay. And the integral outlook. It should be very comprehensive, bringing it under all one umbrella. And we need to have a system that takes care from
birth to death. So that is an important cycle that we'll be talking from. We need a care system from birth to death. So starting from maternity, okay, ending at farewell. So we are also looking at that kind of a space in the health sector. And also if you see the space, try to even in the same corridor from, if you see it in the Mahalakshmi home, Arka, Sante, farewell. So we have some kind of an alignment there, but we need to really work on that. Accessibility and inclusivity. Yeah, somebody told, how accessible is the healthcare system now? So the health sector opens at 8, some close at 5. So really, do we have that kind of thing to seek that emergency care? Yes, we have an ambulance system. Do we have an opportunity to get all the medicine? So there are a little bit of accessibility issues with the current infrastructure and the current placement of these different units. And I've already talked about preventive, I'll not go much into it. And holistic, I've been talking. Research and innovation. So when we want to be a model for the world in the aspect of wellness, we really need to develop our research. And we need to be innovative in our healthcare delivery. We will not just follow what is followed outside. That is not why we are at Auroville and why we are in this health sector. We need to do something different. And we need evidence. We need evidence bases to show to the world. Just say like by just going to Deshakti or the team working with the sports, how healthy can our population be? By taking a nutrition food in solar kitchen or getting nutrition food, how healthy can be? So these are all, I'm talking about research ideas. So these are research ideas that we need to really put it into concrete evidence-based practices. And our care is beyond the physical care. It's rooted more into that conscious level care. That is why we do not only talk about physical health. Yeah. The next slide, please. So here we have our masters of health and well-being. They have guided the way how our health and wellness system should really be looking into it. So we just need to follow based on those practices and preachers. So this is based on the book from the Integral Health and Healing by Sri Aurobindo. Here they say the importance of physical education and discipline for integral health. It's, by just leading a simple life and a purity, we can achieve good health. So we really need to reflect on that. We really need to work, collaborate with physical education and health together. So emphasizes on purity and simplicity of life. So when we have our environment, it is, when we talk about health, it's not only about personalized care. Also, the collective has an impact on individuals' health. So how, as a collective, we can really work on the purity and give us simplicity life. Okay? So the community and collective I just talked about. Psychic being. So health, again, I'll emphasize this because I really like this word. So health is not about this physical thing. It is more about this mental or this social, the psychological thing that you think. Because mother, I remember this quote when I was used to work at Aravind Eye Hospital. The chief, Dr. Venkataswamy, is always saying, he never says that I see a patient in front of me. I see a soul sitting in front of me. So it is, he says, the soul has the kind of faith in me. So mother also says, it is not the medicine that cures. It is actually the faith in the medicine that you put cures. So these are like powerful words, these are like powerful, that kind of a powerful system that we really have to show. And also about the integral view of death. We are open, this is more at the end of life, how to seek spiritually, how to not be afraid of death, how do we handle that. And also about environmental. So how a less smoke area, a less dust area, all this could lead to a healthy life. Yeah. Can we go to the next? So in this document, we have also touched the history of health sector. So the health sector we know has organically grown from a maternal center in a hut at Promise, if I'm not wrong, started at Promise. Then mother gave 5,000 to start the health center or dispensary. Because that time, the resident was more at the aspiration area. So mother started it in the aspiration area, as Torgil now says, but that was started there, but that might not be applicable now. So now we are more moving towards the center. In the residential zone, we want all the people to come to the residential zone, so we need a strong health system in the residential area. And even in that time, we had collaboration with JIPMER. So these were all based on individual doctors who were there at that time. They had some goodwill with Auroville. The doctors from JIPMER had goodwill. They had a connection with Auroville. So we had, if you can imagine, 24/7 care with support from JIPMER at the Auroville Health Center. So anytime night, any first aid, anything would be happening at Auroville Health Center. Dressing, stitches, X-ray, everything would be happening. So then we have come to a system where we have individual-driven initiatives. So a lot of things have come up after that. You know, Pitanga has come, Arca, Quiet Healing Center has come, Matram for mental health has come, Morning Star, Arogya for eye care. So these are all come on organically based on individual. I have already been telling it, individual-driven initiatives. Okay? Yeah, to the next. So yes, we have come to this kind of a step, but we still face a lot of challenges. So there is a chance to overcome these challenges. Okay. So there is a lack. I've been always talking about this lack of coordination. So this did not start in 1 year. Like Surya was saying, it's in the last 1 year there has been a external pressure to really work towards this. But when in 2022, when I joined, when I wanted to come back to Auroville and do my work, the first task that was given to me was, my first post was Sante Coordination Services. So the first task was to coordinate all the services. So a part of that, I went to meet all the providers. I even have gone to JIPMER. We also started this initiative of paying a maintenance for a person who takes people from Auroville to JIPMER. But somehow, without a proper structure, without a proper funding resources, we were not able to carry that forward, and I also stepped down. So there are these coordination issues that are there, and gaps. There are a lot of gaps in service delivery. When we talk about gaps, what do we really need? Do we need a very big hospital? Do we need all the specialty services? Do we have the scope? We might not have the scope. We don't need it. So when we take our population, when we compare it even with the village level, panchayat level, for a primary level, no, the population is less than that. But we can't really go only by the population aspect. We also are now looking as a community basis. So we need certain services, and we need to come up with what are those certain services. So I've talked about accessibility issues. I'll not go much into it. And we also have this reactive approach to health. I really saw this in COVID. Whenever something happens, we react to it. But do we have a model, or do we have a plan, or do we have a visionary plan to take this forward? We really don't have it. So that is why this document comes into place. Yeah. Can we go to the next? So these were the challenges that I listed down. Next, what are the solutions? And how are we going to take this forward? So that is very important. I'll again be using it, aligning. So aligning that is what we're trying to bring into it. We need all the services. All are doing an excellent job in their own domain. But we really need to harmonize all that, bring all those together. So we really need something to do that work. We need a centralization system to integrate the healthcare services. Because now if you see, when we talk about the siloed operation of different organizations, if we just look into even the operational aspect, there will be a lot of duplication of works happening. For example, if I start a unit, I need to get a receptionist. Okay? But if we see how many receptionists there in Auroville in the health sector, there are many number of receptionists. So can we all hold that together? Can we have a space? Can we utilize the resource better? Can we utilize the human resource better? So I did a calculation when I was part of the BCC about how many maintenance are going for only the receptionist. It was more than for the actual clinical persons. So, and then the focus on preventive care. Yes, we have been always touching this. We really need to focus on preventive aspect. When we talk about preventive aspect, not only about in healthcare, nutrition. What plans do we have for nutrition? Are we assessing the nutrition for the children? Yes, we have a wonderful system of the solar kitchen to take the nutritional need for the school children. But why are we assessing it? Are the adults taking the nutrition? Is there sufficient system of food delivery for the aged population, for the population that is in a medical need? We really need to rethink about with that hat. And an important thing is about, do we really have a sustainable financing model to take care of our health system? What is the amount of budgeting, or what is the amount of expenses, or what is the amount of money that is being put to take care of the health of a individual or as a common? We really don't have the exact number in terms of percentage, what kind of a percentage or what percentage of the total budgeting goes for healthcare. But globally, we know this is the amount that needs to go for the health sector. This is the money that needs to go for the education sector. Since we don't have such an organizational structure or goals set for the financing, we don't have an effective financing model system. And when we look about, or we look at our health fund, it is not really enough, or the health fund pot is not able to take care of the healthcare needs of Auroville residents. Because of the healthcare cost that has been increased in the post-COVID, the healthcare cost outside world has increased maybe 5 times. So we don't have an exact financial model. And we need to really strengthen the health infrastructure and staffing. We need equipments. We need basic equipment. We need human resource. We have human resource. We have a lot of people studying in the health sector, but do we have the opportunity, or do we have a structure, or do we have a training program to use that manpower? No. So we really need to work on the human resource part of it. And yes, long-term plan. What is our long-term plan? So now we are a population. We are looking at a population. We are looking at an aging population. So what is our long-term and short-term goals? We need to come up with this plan. Yeah. To the next. This I will not go into much. The document also focuses on the care or the wellness that is required for the different stages of a human life. Okay, we have categorized it. It's not, I think it is an evidence-based research, and we have taken that kind of research papers, and we have put this kind of an age categorization so that every individual, every child, every individual, every adult, every aged person is able to access the care, and we'll be able to come up with a policy that needs to address all these aspects. Yeah. So with this, in our brainstorming session, along with the different health sector team, we came up with these three main domains. So the document will focus on these domains, and the initiatives that we have taken, we categorized into these domains. So the proactive health initiatives. So we have put a few, we have listed a few of this into the proactive, then comes the curative, and then comes the supportive service. So we're trying to club all these services or units that provide this kind of a specialized services under proactive, curative, and supportive service. For example, Deshakti might be a separate unit, but we'll put it under proactive. Solar Kitchen might be a different entity, but it will come under proactive health. Yeah. Can you come next? Or you, yeah. So under the proactive health initiatives, we'll need to really work on the preventive care aspect. We really need to invest more on preventive aspect. Nutrition programs, yes. Solar Kitchen is giving a nutrition program, at least one meal. But could we enhance that nutrition? Could we have a nutritionist assess that? Have we assessed that amount of nutrition that is there? We all need to really work on that. And we also need to work on the social and collective health. Collective health is taking care of our own residents, giving a good environment to work. So all this comes under the collective health. Family support systems. We need to really work on assessing or also handling the family support, with the, maintaining the work-life balance, all that under that part. Health education research hubs will come under the proactive health. And caregiver support. So caregiver support, we can talk into two aspects. One is we need to increase our caregivers. We need to train them. We need a lot of training programs to take care of our own residents, the residents who are aging, who need specialized care, and also care support for people who are in the health sector. So people who are actually in the health sector need a special support because they work with people. They are overburdened, they work beyond that normal thing. So they also need that support. So I'll put it into two aspects. Support for training and also special support for people who are already in the health sector. The next. So curative is when a problem happens, we need to take care of it. Maternal child health, allopathic and alternative medicines. So right now, if you know, Health Fund only covers allopathic practices. But we do not want to move towards only this one direction. So alternative medicines could also be as an option. Holistic healing services, body therapies, all this could also be part of the curative process. Mental health, rehabilitation and recovery. So we don't really have a support system for people who need a curative support but who don't really need an hospitalization stay. So recently, to bring to the hall, ARCA started a system where people who do not need to be in the hospital, okay, can be there in the special room. Okay, they need care, but they don't need a hospital care. So this could really reduce the cost and also give this curing environment or the caring environment for our own residents. And emergency and medical services. We already have an emergency system, but we need more data-driven based emergency. Like, for example, we need systems for blood donation. We don't have a system. When there is support needed for a blood transfusion or things, we don't have a system. Next. So the supportive services, these are the services that are included in the supportive services. Senior care. So senior care is a very important topic that we really need to talk now, because there is a huge demand for senior care rooms, and we don't have them. We need to think out of the box for senior care, and we need to have a plan for the senior care, and we need to have data management. We talk about health. Yes, health data is more privacy-related data, but we as a community do not have health data. Diabetics, or like we don't have information about how many people are diabetic, who need diabetic diet. We don't really have a data on snake bites, scorpion bites. We don't have data. We really need to have a centralized data systems that can give us evidence. And yeah, the health fund comes under the supportive service. End of life and palliative care. I'm not going to talk into it, because we know all that. Farewell is doing an excellent job, but we really need to have a support system for that. And we have put another aspect is the nursing network, support network. If we see, there are a lot of nurses in Auroville. Even Auroville residents are nurses, working in different organizations, but they don't have a network. If we need a support, or we just need an injection to be done, we could get our own fellows support. So we are trying to bring this nursing support network active. Yeah. So this is all that is being covered in this document. Yes, we have come up with what are the gaps, what needs to be done. The important question is, how is it going to be done? We have had, everybody is busy. In the health sector, I said, everybody works more than what they work. But we really need to get things going forward. So for that, the proposal is to establish a well-being coordination group. So this group is going to be the overarching, or I won't call it as a control system, more the system that oversees all these activities. Okay? So this group will be representatives from all these aspects. I said proactive, curative, and supportive service. So there will be representatives from all these subgroups. And it will be not a permanent membership. It will be a rotating membership of 3 years. And it needs to be rotating. And in this subgroup, so one important thing is, people in the subgroup can be working in any of the activity or running their own activity or thing. They can be part of the members, the 9 members. But out of that 9 members, we propose that there will be 3 core group members. Why there's 3 core groups? So once the core group, they won't represent any individual services or units. So they will be only representing the WCG. The role of them is to only care about the overall health of thing, what all is put in the document. They will put the hat of the WCG and work towards that aspect. So we are proposing it to be a full-time maintenance work, because there is such amount of work that has to be done with the coordination. And when we see this is where, if you see this diagram, we just try to put WCG at the center. So here we have the governing board, FAMC, and the working committee. So we have the administrative organizational structure at this side, the different units and activities, and at the end, the resident. So this WCG is going to be in the middle and the sole organization that is going to take all the decisions from the residents towards the GB with the support of the FMC, and same thing also bring the information from the FMC GB to the residents. So that is going to be the central holding group. If put it very simply, something like what Torgil said, like this here, for education, the WCG will be for the health sector. And we also propose one secretary full-time to carry out the operational works to, to keep it going. To the next. So we have, yes, we can develop a group. But what happens, so how do we make this group work active and hold the responsibility? So we have also documented in this document the key responsibilities and the roles of this WCG. So this, all that is being mentioned here, will be their key responsibilities. So coordination and development, strategic planning, long-term as well as short-term planning, collaboration with the health and well-being units, budgeting, supporting the BCC or the FMC in budgeting, and also overseeing the financial management. Policy formulations. An important aspect that I didn't mention, health is though a fundamental need, it is regulated by a lot of state level, central level regulations. So we really need to have an organization that really works on the policy formalization. And if required, it will form subgroups to really work with the proactive, curative, or the supportive team. And also an important part is asset management. So all the assets that is being effectively utilized or any new asset that is required will be all controlled by this WCG. And it will also get involved in community engagement, meet the community, hold meetings with the community, get feedback from the community, and work towards that. And also about monitoring and improvement. So if something is not measured or something is monitored, we can't improve it. So this group will have maybe indicators or key performance indicators that will really measure. Measurement does not only be quantitative, it can also be qualitative. And this organization will be working with the collaboration of external bodies. For example, a collaboration with JIPMER to bring a staff. So all this external collaboration will be handled by this WCG. And this will work on health education and research. There are a lot of volunteers who come. If an organization or a unit needs some human resource to work on a project, so this WCG will be the organization that will support that particular unit with this research activities. And a key important aspect will be the human resource development. We actually have a database of people who are in the health sector, who are completed the health sector, who has done a bachelor of optometries, or who has done physiotherapies, who are the doctors. We have a database. But to develop this and to bring a human resource core team, the WCG will be handling it. Yeah. Next. So we have not only ended up coming with the roles and responsibilities, we have gone a little more deeper into that. What will their work schedule be? Like what they should be doing. What their daily work will be. What their daily meeting. They won't have daily meetings, at least weekly meetings among themselves. Weekly meetings with this proactive, curative, or the supportive team. They will have meeting with them. They will go and visit their services, so all that. Monthly well-being meetings, like open houses. People can come and meet them. So quarterly larger meetings and special meetings for budgeting, and if there is any policy mandates or policy work that has to be done, will be carried out by this WCG. Yeah, to the next. So that ends the work of the WCG. And now we come to another important aspect of health financing, the funding. So funding is an important aspect for health sector. So WCG will support in overseeing the funding and also help in getting projects and funding. So the fund allocation, the plan is to have a wellness fund. Normally, the health fund is already there. So how this will be different from the health fund is, the health fund is more, I've been talking the curative part of it, but more from a larger fund that can also support units or services. For example, we can have services, wellness services that can be, I don't know, I put it in the right word, commercialized, generate income. But that income towards this common pot can be brought to this common pot that could be used for the community health services. So we are not, it's not that restricting that everything should be a service. Yes, wellness or therapies can be commercialized, but we'll get the support to take care of the health sector of the residents. And fund generation includes writing project proposals. Health sector is one area where we can easily get funding support. It could be corporate funds. It could be maybe a fund from SBI to get an ambulance. It's easier to get a fund. So the WCG will really work into it. So we need actually, so the fund generation will be more towards new projects or infrastructure development, not for the operational activities, for more that part. And also we'll need to look into the cost mitigation factor. I've been talking about, since our health sector or the health fund is dependent on external, we really need to think about the cost saving factors. I said one example. Instead of staying in a hospital for 5 days, can we stay in a hospital for 2 days and 3 days in Auroville? Where we have a space, where we have a good environment, where we have a good nursing care. The other aspect is also about insurance schemes. Torgil highlighted that point. Can we work? We have a special visa status. Can we get the government insurance schemes? Can we have some understanding with JIPMER where the staff or the residents of Auroville can get some special services at JIPMER? So all this cost mitigation will also be part of this. So for this, we have touched, so the document starts from there, wellness, and finally comes towards how we are going to fund that and fund the overall health system. Yeah. Thank you. With this, I end my presentation. And so this is whatever I have presented here is the glimpse of this document. And as I mentioned in the beginning, this is still, yes, we have not actually finalized this. No, it's still in the process of changes happening, which is really relevant, required to strengthen our wellness system. So this forum, now we'll open it up for the question and answers. And we'll also want your questions maybe focused on the presentation or towards health sector, so we can really use those feedbacks or suggestions to improve this document. Because once we give this, it becomes a more comprehensive document that we hand over. And if you are feeling hesitant to ask your questions, we will also give you a piece of paper where you can put your questions, or you can also put your suggestions on that. If anything is missing or you would like to add anything, any suggestion is welcome to put it in the document. Yeah. Thank you. So we already have.
Thank you, Sugan. So we have about 10 copies you can distribute. We don't have many, so please share. We will later on share a digital copy of this. Thank you, Sugan. Yes, we will go to the question. I am Lakshay, and as part of AWARE, I assisted Sugan and Surya Gandhi and Torkel in little bit in the workshops and basically provided secretarial assistance. So I'm happy to get your questions and try to see who can answer you better. If you want to raise some, yeah. And feel free to ask, whatever. Ask freely, and I'll try to answer frankly. Yes, to begin with. Wait a second. Take a microphone. Raise your hand, Anita, and on that side, Raja is there to assist you. And
Hello.
please mention your
Hello.
name. Yeah.
Hello. I have a question. You mentioned that, first of all, thank you for your presentation and for the work that you've done to organize something that is very complex and very close to the hearts of many of the people here today. I had a question about your saying that this document is created by people who are not necessarily healthcare providers, and then it goes on to the FAMC where, again, we do not have healthcare providers, and then it goes on to the governing board. My question is, how qualified is the governing board?
Thank you. Little bit correction there. This is conducted by Surya Gandhi. She is a trustee of Health and Healing Trust and assisted by Auroville. FAMC and me as Lakshay, as I said, it's just secretarial work. So it is, and then in the workshop, Surya Gandhi Akka from her trust, she shot off email to all the units requesting them to be part of the workshop multiple times. And few times we gathered, yet we did not have enough quorum, so we postponed. So this exercise went on for 3-4 months. So even after that, I agree, it was not populated by all the healthcare professionals, but it's up to them, not up to us. We really tried our best to get everyone on board. Beyond that, as we said, we also opened the document. This document was open for comments, even if you did not, or the healthcare professionals who were a little bit shy of attending the workshop, we said you can comment anonymously also. It was shared, you were part of that group. Having said that, even today, as he repeatedly said 3 times, that this is not yet final. So even this exercise is also one more opportunity for those who would like to contribute. After that, yes, we all can question the veracity of GB or people like me and keep on questioning, but that would not solve anything. Why would you, okay, question again.
My question was
why there are no medical people in the GB?
No, I don't know who the people are on the governing board, but my question is...
Right now. Perhaps with IAC you can take it up. Anybody else? Yes, please. Please mention your name.
Hello, Alexei is here. Sorry, loud. I'm impressed. Quite good work. What is, from my point of view, is missing is in the main principles, which was the beginning of the presentation, it's an individual approach. Because each of us is individual. As my experience with the patients, I see that 99% of patients not interested in the health, they're interested not to be sick. People looking for a fast solution. The change of the paradigm need to be happen for there. Otherwise, everything is just waste of the efforts. It's one of the reasons why I quit medicine. Because it's very heartbreaking experience just to see that you're trying to help, and instead of gratitude, you have a question, but why you don't prescribe me more medicine? Why I should go jog or walk, health, change my diet? Just give me one more medicine. Yeah, so, and also what is missing is a standard medical practice in India, in Europe, in Russia, whatever you say. We have individual body. If you go to Ayurveda, we have different bodies, and they have need different approaches, different lifestyles, different foods. Everything is individual. And from this individual position, we also come for an individual responsibility for our health. For example, I will not mention name, person, chronic smoker, lost one leg because of smoking. It's burden for a society. He receiving money from Silver Fund, cover all his medical expenses from the health fund. So why as a society we are carrying responsibility for such a person? It's human. Yes, I understand. Can we prevent things like that?
Okay. So if I understood your question and if I see if I'm answering you rightly, there will be such instances where, like you said, individual choices may lead to certain healthcare requirements. Should we as a collective provide for it? Is that what you're saying?
Yeah, approximately.
Okay. So when we are creating systems like this, when we are creating organizing model, should we look at the chances of somebody misusing the system or look at the bulk of the people who have requirement, genuine requirement? So I would rather look at, say, 80, 90% of the individuals who would honor our collective organizational systems and respect the, the fund or whatever, facilities it provides. However, you are right, there will be 10, 5% of them who will misuse. And perhaps we will, it's not yet final. On the go, we will set up systems temporarily to look at those aspects. No? What we try to do is, if you look at it, the presentation that Sugan made, we have not gone in detail about what are the practices. It's generic. We said proactive, curative, supportive. So in curative, we didn't get into homeopathy or Ayurveda or is it, some other Siddha medicine. We didn't get into it. It's something which the system will take care of it. We are only looking at the organizational aspect to also answer yours.
And just one more remark.
Yes,
the health need to be also a part of the city infrastructure. It needs to be brought to ATDC.
Absolutely.
Because, look, I'm jogging along a road, 10 bikes passing. Do I make a healthy jogging for myself or not? Why our cycle paths goes along the road, not in the forest, and so on, and where they are, basically.
Yes.
Yeah. Okay, thank you.
So a part of this, like he mentioned, WCG is at the crossroads, which will then formulate this proactive needs of the community, like even if it's cycle paths, walking paths, or nutrition, or some other activities which may influence, like even little bit promoting health activities or sports activities, in the evening for all adults, like in ashram. If we can promote such, again, these things cannot be forced upon. What we can do as WCG is nudge the residents slowly, positively, inspire them more like. So if they come together like this WCG and then they say that this is an idea, like he mentioned, one of the roles and responsibilities, take it to the community, have this kind of conversations, and then harvest more ideas, put together as a more concrete proposal, then give it to FAMC, ATDC, who will then subsequently take it to GB, get funds, or raise more funds, or go to AVI. So all these ideas, right now we are stuck because we do not have a body that comprehensively looks at the needs and provides for it. What we are trying to do is, we are again imagining, can this WCG be that useful body? Thank you.
Yeah, it's a good idea, another group again. And for me, the most important thing is, and I think for most of the people in Auroville, is how you're going to give these roots, how you're going to do it. It's very nice to have this full capacity and idea, but what I also say, how can you, it will be more interesting to see, are you going to enforce this? Is it going to be voluntary? Is there any change, is there any change into the health fund situation at the moment? I think most of the people, if they're not necessarily themselves working in the healthcare,
this is what it would be very interesting to see what are the ideas about that.
Thank you, Sonia. So the 9 members that he mentioned also, what we imagine is that we have these 3 sectors, proactive, curative, and supportive. We will invite people to nominate themselves to be part of WCG. So imagine, so this also creates an opportunity for not just, let's say that we have, say, 10 nominations from units like Sante, health services, pharmacy, then we only have representatives from curative. So the idea is to then open up, then it's again the part of WCG to see, can we invite Deshakti? Can we invite Solar Kitchen? Can we invite some other entities which looks at proactive? Can we invite Sire also to be part of proactive? Can we invite nursing? Can we invite the ambulance to be part of supportive? So provided there are nominations, then perhaps it is the role right now, it is the role which FAMC will take to choose amongst the nomination 3 members. Right now, that's how it will be on a practical sense. Later on, we may change. But for now, given the ground reality, this is how it will work. So 3 members each. Like I said, one of them from each sector would be requested to be a core member, which means full-time work. Even if he is working in Orokia, he represents the curative, he will be asked if he wants to be a core member, he has to leave Orokia to somebody else and manage this full-time. Because one of the other learning from our working group is that this one-day meeting a week or half-day meeting a week is not enough to support what we need to do. So these 3 members will meet every day. Next slide, please. That's the whole idea of this organizing the time frame also. Can you go to the next frame, please? Yes, so daily work. So this 3 members plus a secretary will work, meet, they will have an office, they will have a maintenance to do this work proactively. The 9 members will meet weekly, all the 3 representatives. Monthly well-being meetings is where they can open up this kind of session for, let's say, only curative units. 20 units come here, they say, we need this, we need this, we need this. So they may collect all the funding requirement, whatever staffing requirement. So quarterly community meetings, then again they open it up for meetings like this where they can see what is the mood of the community at large. So all this is a regular work. Now coming back to how it will be practically used. Imagine tomorrow after this document is ratified, let's say by GB, and they ask for nomination, and let's say only 5 members nominate themselves. And FAMC may nominate whatever 5, and remaining 3 or 4, they may then choose themselves, whoever it is. The work will go on. It's up to us if we stand up, take up work, or else perhaps like other things in Auroville right now, there will be OSDs. I'm trying to be as practical as possible here.
I think we are not proposing any direct changes now. Like, for example, you asked if there will be changes in the health fund. Right now, there is nothing that is happening in the document that we are going to change individual units. But that will be up to the WCG. Because if you see the health fund, I'm just giving you an example of health fund. We have the funding for the curative services. We go to the hospital. Then we also have something for the dental. Separate, you have a separate funding here and a separate funding here. But we see it's all the community fund. It's all the fund that goes from the common pot. But we have different channels to route the fund among ourselves. So if WCG thinks there is an important step that needs to standardize it, yes, it could be. But right now in this document at the proposal that we say, we are not going into individual units or services or changing their structure. We are not proposing it because it could be backfiring. It will be difficult to do it in a single document.
Hello, have one more question? Hello? Yeah. One question is also well-being. Like there's a whole section of well-being in Auroville, like people that need a massage, that people that need to, also care at home or care when they are recovering. Is this like going to be included now into the idea? Because when I now need a massage, I pay for it from my private fund. It's not in the health fund. So there's a whole group of like huge amount of people that are therapists. Are they going to be included in this? Are you planning to include this in the program, and how would you think about doing that?
I'll again put that will be the part of the WCG thing because it is very complicated. If I give a massage offer, mostly maybe everybody, all the units doing massage, financial might increase, but does it really add value to their clinical aspect? So that is very important. So it's a very tough decision that we make, and that is why we're not touching that now. For example, I talked to Surya Gandhi, dental. If we say dental, the question goes there. If I don't maintain my oral health and I want to community to give my dental reimbursement, it does not work. If I don't brush teeth properly, if I keep smoking and I go to a dental, I say I want to use the community fund to do the dental procedure, it does not work. So there we can come up with procedures. I think that is the work of the WCG. What can be covered? Okay, in health, it is not that everything will covered under medical. If you just see in health fund also, if you use a gloves just for examination, it does not get covered under your reimbursement. So similarly for health, like massages or therapies, it's very tough decision to make whether that will be eligible or not eligible. I think that is where the formulations, the guidelines, the policies would need to come up. That is why we need the support of this preventive and curative team. So they will come up with their own guidelines and they will bring a proposal to the WCG and which can become a policy. So that is how we want it to happen instead of posting it from the top down. Yeah.
If I may expand the question and also little bit say that what will happen to all the services, massage providers and other healing providers. Let's say we take this example of dental itself. If they come under the service, then most likely, I'm not saying it will happen because it's a decision of WCG, most likely it will come to the crown. Like he said, to Sante, Orca, it will be, the idea is to bring to the center all the health services, which means all the requirements, the infrastructural needs and even the maintenance will be given for by the collective pot. No more fees and all. We need to go towards no money, which means no more of those things. Then you may also decide that for our proactive well-being, we need 4 masseurs or 2 homeopathics or this and that. This will be decided by the WCG and that will be provided for by the collective pot. However, we may have 20 homeopathy therapists. Like even the example of this Aurodent, perhaps this dental service can come to Auroville, but you may also have additionally Aurodent which may act as a furtherance activity. You may have 10 other dental related services like Linea is there. No? Yeah. So you may have multiple. However, they will not, in terms of asset allocation, will they get in ARCA? Most probably not. Again, not my decision, WCG's decision. They may start in Auro mode, Auro leg, wherever, but it will not be in the space which is maintained by the collective money, which is mainly, the whole purpose is to serve the residents, not to make money. Which means we may need to go away from this charging for everything. It will be a great boon if we can manage this. Again, this is where we put a lot of effort on finding out the finances to manage it. Long answer for a short question, perhaps. Sorry.
All right. Hi, I'm Krishna.
Yes.
One suggestion is that maternity care needs to not be under the curative health services, but under preventive, because maternity care is foundational for public health. So I think you need to adjust your understanding of what is the basis of public health and how it works. So that is a suggestion. Another one is you mentioned work-life balance as part of public health initiatives. Are the current maintenances going to change to reflect that need? Because currently a lot of people are working a lot of hours out of need because they're not able to support themselves. So is that going to be changed? Has there been any kind of discussion around those things?
Frankly, no. No for the second question. The first one, if you look at the term nomenclature, we didn't say preventive, we actually mentioned proactive. So it is more towards health education, it's more towards research. So the maternity or or other needs,
maternity-
it becomes part of the central aspect where you go there when there is a requirement. So the other proactive is when it's just taken care by the community without even a need. So that's a small difference. I don't know if it answers. The second aspect, maybe FAMC, you can answer it. Do you have any plan to reflect on that so that people's needs are met?
FMC don't have any actual plans of actually changing anything, because we need a comprehensive plan to do anything, because whatever we have now is so complex and often not fitting together. So just trying to change one part of it doesn't make sense unless you have an overarching plan where to go.
Can you reformulate the second part of the question?
About work-life balance?
Okay.
Okay, so if you're mentioning work-life balance as a public health kind of initiative, are the current maintenances going to be changed to reflect the actual needs that people are having? Because I can see that from your diagram, you know, if FAMC is a part of the circle somewhere, what part are they going to play?
I would say absolutely yes, but that answer is from me. We need to go towards a system where the needs of individuals are met, irrespective of where they work. We need to decouple the place of work versus the maintenance. The maintenance is not a compensation by any means. It's only a basic needs that we provide for. Eventually, we may also go towards a system where it's not that you get a cash and then you go and reimburse somewhere through this kind of services. Can we create a system where these health needs, education needs, all these needs are met in a more systemic manner, that you don't even need cash in between, that somebody provides you the cash and then you go and pay for it in pharmacy or in other places. So can we go towards that system? Right now it's unknown, uncharted areas. I don't have answer.
And I actually do have one last question. There was a mention about that the maintenances for receptionists exceed that of the practitioners. And I want to know, is this because there are actually more practitioners than there are more receptionists than there are practitioners, or is it because there is not actually enough maintenances to go around? And so receptionists are being prioritized because practitioners can generate income from their work. Honestly, because I think it's just, I just want to say that it's twisting the numbers a little bit.
Fair enough. So that was an example that Sugan gave here off the cuff. We did not discuss it in any of our workshop, and that was not the purpose of this exercise at all, to look at the numbers. It is perhaps the work of WCG when they are constituted. We didn't look at the numbers, how many practice. We don't have the data, by the way. This is something which we want. Again, one more supportive services, if you have seen, data management related to healthcare, in terms of also the needs of the residents and also the number of practitioners we have, who is the right fit. We don't even know. And then there is also, somebody also raised the issue of privacy. If we manage such data, having such close community, how do we deal with it? So there are so many, as I said, uncharted waters we do not know. We will cross the bridge when we reach the bridge. Any other question? Yes.
Yeah. So the example that I quoted was for the duplication of work. So it is not actually the exact numbers, I'm sorry. It is the duplication of work in terms of every new unit that starts need a receptionist. Or you need somebody to answer the questions or answer the phone. So it was just an example to quote that part. That means, like everywhere individually we start a unit, we need a team or a human resource to do this work. So it is in that context, not the exact context of the therapist. Yeah.
Any other question? Mic there, please. Okay. Yes, Bianca.
Sorry, I'm Bianca. Who will be in charge of creating the new policies for the health?
Previous screen.
No, with which?
Previous one?
With what skills? So who will be?
Previous screen. Yes, I got it. Okay. So as I said, FAMC provided this document is presented to GB and they get the blessing from them. I'm not sure how qualified are they to bless, but they can nevertheless bless. And then once this WCG is formulated officially, like he mentioned before, it will act like a sire, right? Right now we have in sires a Sanjeev Ranganathan. Who is he? We got him there because he is part of the sire. He teaches in one school. He's responsible for one school. Similarly, in WCG also, most likely it will be constituted by people who are working on ground in the health sector. It does not make sense to put me there, right? So, but I can be there as a secretary. But as a WCG member, to take decision on curative or proactive or for taking a supportive services related decision, you need to know the nitty-gritties of that sector. And it is only right that, like I said, if there are enough nominations, let's say 15 nominations, perhaps the prerogative is with the FAMC to choose 9 members and make sure it is nicely distributed amongst proactive, curative, and supportive. And in case, like I also mentioned before, there are not many nominations, it may take a different route also, and I do not know. I don't want to say that it will happen that way only. It may work with less number of members also. But ideally, WCG will be constituted by members from the health sector.
And another question is, okay, I understand, I'm aware that this is related to the general organization system structure. So it's not into the detail, the practical details. But as Sonia said, the Auroville has a lot of therapists in many fields. So not only massage, but healing,
yes,
therapies. So I think it's not an aspect that can be ignored in the organization of the health system in Auroville. So what is the idea related to the great number of therapists that can be useful, great use for the proactive, the preventive health style of Aurovillians?
Great question. I will also a little bit expand the answer beyond what you just asked. I think going forward, like I think she was mentioning that there are about 50 therapists who are registered as part of the booklet, various forms of therapists. Oh, 150.
Yeah,
okay, so
maybe even more.
Okay, so there are many who are registered and not registered. This is a very crucial issue which FAMC is dealing with right now, and it also has an implication related to law of the land, because some of the activities or the therapies that they undertake may not be officially recognized. So how does FAMC take a decision on registering? In fact, if you say that I want to start a new activity, on what basis do they say that it is a good activity to register or not? So this is where they come to FAMC. They may send that letter. They may say that go get an approval or at least talk to WCG people. Once they give a recommendation, we will register it. So what we are trying to do is create a community life which is beyond money, right? Right now it's all service charge based. So this system is only for that, to organize our needs of collective life, which means even if there are 150 therapists, it's not possible to give them maintenance and say give the service for free. Not possible. So some of them, and also we need to let those individual people practice also. We cannot control it. So most likely, the way I say it, I do not know, it's a decision of WCG. Most likely they may absorb few therapists for a proactive health, and the remaining ones will work outside the purview of this WCG. But they may contribute to Auroville through making money, no? I hope I answered your question.
Yeah, I was not thinking about the money. Okay, it's important because the health system needs to be funded. But I was thinking about the contribution, the practical, healthy contribution of these different operators. Because, for example, I've been told that at the moment, a person that wants to start an activity as a therapist cannot because it's only one person, so there is a preference to have more. So I was just trying to understand what is the situation in general for therapists outside of the general organization of the provided health system.
Okay, Torkel, may I invite you to answer this? Imagine I apply to you for a new activity. I want to be an art therapist. How will it work?
I'm not sure I can give a... First, there are rules for which...
I'm a role practitioner, I'm an art therapist. I want to start an activity.
Art therapy, yeah, okay. I think you will be approved to start a unit, but if it's a part of the healthcare system and supported by that, I think we need to get a guidance from is that. I doubt it. You see, any country can spend 100% of the income on health. There has to be a stand on how much you spend. And I'm actually not here as FAMC, but I actually, before I came to Auroville, I worked a lot in healthcare systems in development world. So I know a little bit about healthcare. And there is a limit to it. Until a certain degree, and in a country's development, you can spend a lot of money. Over that, there's no limit to how much you can spend, because people can feel any need of money that can be spent. And if you compare countries, there's actually no relationship except for poor countries. But for richer countries, how much they spend, it does not really come out how healthy the population is. One of the countries who spends most in the world is actually USA, who spend close to 20% of their GDP on health. And nobody thinks, even not the Americans, think it's a very good system. Most European countries will spend 10 to 12%, and they have a pretty good system. So you can't say just spending a lot of money on health will actually improve the system. But to answer that, I don't know. That's why FAMC needs a group to assist in deciding what funds should be used for. FAMC will decide how much money we can actually spend, but it's very difficult for FAMC to decide exactly what to spend this money for. So in any system, any country will have a health ministry to guide them what actually to spend money for, because the politicians or whatever who normally takes the decision, they are not practitioners, and they will not be know. But if practitioners should decide, I'm sure you will spend 50% of GDP on health, and that would probably not work either. So there has to be a balance between somebody who says we don't have more money, and somebody who can guide us what is the best way of spending this money. So that's the only way I can answer.
US is perhaps a bad example. 18% of it perhaps goes to pharma. Okay, please, next question.
Okay. So I would like to suggest that there be a group or an emphasis in this healthcare system that really takes in consideration the family as a unit. Because when I speak to mothers and fathers across the board, be it Tamil families that have Tamil families to support them, that have large extended families, they're struggling economically. And when I talk to Westerners, they're struggling economically also, and that they don't even have support from extended families, grandmothers, aunts, uncles. It's a lonely game to be raising a child here, and I'm noticing that many people are deciding not to have their babies here anymore because we can't have them at home. And that's why we're building our birth center, because Tamil Nadu wants 100% institutionalized birth. And so because of that, some of our wonderful couples and families are leaving Auroville. And then also because of the cut in many of their salaries for the fathers and for the mothers, there's a huge struggle, and then there's also a lot of leaving of our community. And so I'm really concerned that if there's going to be a large community here, it's built on families. Schools are built on families. And if the children are not held in a whole way economically, if they're not held, if the women aren't held in their pregnancies well, and in the way that we kind of ignore the care for them as a unit, because I see fathers are just as stressed. I talk to many dads, and they're just as stressed as far as and stress is the #1 cause for ill health. So if there could be, in this structure of care for Auroville's health and well-being,
something that is specific to the care of family as a unit. How's the mother and father doing? And what you'll notice is that mothers who have like 3-year-olds or 4-year-olds, kids that have snotty noses and can't go to school, and now they have to leave their workplace, and now they don't have, the structure isn't set up for there to be childcare or to be working in Auroville and at the same time taking care of small children. We have totally let them fall through the cracks. And so there needs to be a systems thinking around families, and it needs to be taken very seriously, because you lose the quality of your community if you don't care for them.
Thanks for bringing it to the notice. Actually, we didn't let them fall through the cracks. On page number 19, under proactive services, the third service is social and collective health. This talks about the collective aspect. In Sri Aurobindo's words, there are 5 planes. So vital care is very much necessary on an individual and a collective level. And the fourth aspect is family support services. We need to invest on this. You're absolutely right. Thank you.
I was really specifically wanting to look at their economy, look at how we're paying mothers and fathers so that they can be with their children when they're small and as they're growing, and that we really, there's paternal leaves, we don't really have a good game around that, and we're not doing it well for women either. So we kind of fall way below the standards that are the best in this country, in this world. And so I just want to look economically at what we're doing to families, and also just how we're caring for their health. We don't have anyone caring for the health of babies or little children, and it goes on and on and on the list.
Valid point, but from an organizational point of view, it cannot be on an individual basis. It's just not possible to take decision on an individual level. We need structure, we need systems. So this is again the 5th point, health education and research help. We need data. We need somebody to research on the correlation between economic woes and the health effect. Perhaps also the environmental bliss that we live in and its effect on our health. So these are the kind of health research initiatives we need to undertake. And if there are some red alarming flags, then we can address it again through proactive investment on it. Thank you.
It was a question also about health. I'm thinking about ending his life in Auroville. I want to visit a lot of people in the hospital, and could we be aware to have a place in Auroville, especially for the end of the life, being able to do palliative therapy and so on.
Yes.
And another question.
Yes.
Sorry.
Shall we go one by one? Yeah, okay.
This is a very quick question.
Okay.
The members, sorry, I came late. The 9 members rotating could be also a practitioner, doctor?
Absolutely. Absolutely. So 3 members are from curative. So those can be doctors who are practicing. So there is a correction. I said I cannot be, but I can also be in a way. I'm sorry, I want to correct. I was thinking after that I am part of, I am into communication and awareness, so I can be part of proactive. I can nominate myself to be part of the proactive healthcare to spread awareness related to health. So I can be, in that sense, structurally there also. To answer your aspect of palliative care, again, we have, it is there in page number 21, end of life and palliative care. We have accounted for it during our conversations. Thank you.
Yeah.
What was the second one you said? Sorry. Yeah, I answered. Thank you.
I'm happy to see the entire presentation, mainly the vision statement, and with what vision you have started and all these details. Once we stick to the vision, then people would come and they work, and the things will take shape gradually. And like a 32 kV electric line goes and you can plug something. And if the structure is healthy and sincere people are there, it will work. But it will evolve in time. You see, the richest country of the world, having in the richest state of that country, and the worst fire is there. And Trump says that I could have built a whole reservoir and could do that. But you see, the best that you could give with the present resources are everything, but there is something which would escape your vision and state of understanding. But with goodwill, we can progress. And I'm happy that something new is being happening, and all the coordination and everything is planned. I'm not in the health sector, so I can't comment on anything. But as I see, as an Auroville thing, it is good. Thank you.
Thank you for saying this, and I also add my vote of thanks to this because I worked very closely with them for the workshop. So I see the hard work that they put in, all the selfless work. Thank you, all of you. Anybody else?
Can I? Preventive and community care. I think, and I'm very happy that we have this kind of interaction, and that it's been a long time ago that the public has been invited to participate and put their input in. And I think at the moment, the lack of this kind of interaction on the community for whatever happens, what happens to me, every week I get another mass mail with decisions. And I think the whole community at the moment is under a big stress. And we have seen a lot of people dying this year. And that could be because we are all reaching towards 80. But if we would think about how we want to really take care of this community and the health, I think we need a healthy way how to interact with FAMC, with the GB, and with the community as all. So I really would like to ask if you're really serious about wanting to improve the health care of people, this would be the first requirement. On the community, care of community interaction, care of working and solutions and information together. I think it would do a lot of preventive care, because I see that my nerves and all my friends' nerves are scattered from the last years of this kind of lack of information and lack of interaction and lack of recognition. So that's I would like to say also.
Thank you. I think something for all of us to reflect. Anybody else? Is there anybody else already? Paula, we come to you after.
Well,
we come to you next.
Okay. Oh.
My name is Raghu. I want clarification on this. Is you mentioned about the example of therapists you talked about. If somebody is providing service to the community, they'll be along the Crown Road, and that's supported by the community. But others who are not, who are doing on a commercial basis, they can be elsewhere. So my question is this structure that is here, who will be making the policy, etc., is it for only the services provided for the community? What about the rest of the units, commercial, non-commercial, what it might be, who are involved in the sector, in the healthcare service sector? Does this involve them or not?
Good question. I think it depends on the unit themselves. If they are ready to transition towards serving the community without charging, they come under the purview.
No, I get that. But doesn't it make sense? Because this is basically a sector, health sector. It involves all the people with specialist experience in the health. And health sector, by definition, is very interdependent, interrelated. In fact, it is an environment in which all the specialists function. A hospital cannot function with a pharmacy or a diagnostic, and so on and so forth. It's a complete environment. So doesn't it make sense to have all the specialists under the umbrella, but there could be specific policies towards those who are working for the community, supported by the community? That's completely all right. But the policy should involve all the specialists who are there, because there's a lot of sharing, and even if a unit is outside, for example, let me take an example in the food sector right now. You may have a solar kitchen which is primarily meant for the community, but you have a restaurant outside which is serving everybody else, where also Aurovillians go, and also guests come to the service and solar kitchen also. So similarly, if there's a healthcare unit which is serving only the residents in the Crown Road, guests also might come, as it happens now, and the other way around also. And in fact, whether the unit, whether it's inside or outside, doesn't matter. They all need the supportive services of other healthcare related services. So you cannot distinguish between them, but you can have specific policies. I think there's a lot of synergy giving. We are 3,000 people. How many people are in the healthcare sector? And to build an environment like this, you need a massive resources, massive people. It's not very realistic. So therefore, it makes sense to make the best use of all the people we have in the community, to tighten it up together, and also to understand what the issues are. I was looking forward to hear that. You must have had this in the discussions. It's not presented here. If you ask each of the healthcare providers here, what's the #1 issue you're facing? What is the issue for Morningstar? What is the issue for Mahalakshmi? What is the issue for pharmacy? What is the issue for the ambulance services? I don't know. If we solve those, they will automatically start working together. It's not that they don't want to work together. There are limitations to that. In the healthcare sector, I don't think it's because of anything else. So I think we need to address those infrastructural issues and get better out of what we have now. And this structure is absolutely forward-thinking. Great work has gone into it. I believe that can work. But I'm also afraid it'll create another layer, because, as I said, we have very few people in the community who are capable of, who have skills and time and energy to do it. And you're all drawing some more of the specialists into this group. Okay? And we're going to have more and more of layers, in between layer, because they're going to formulate the policies, but the execution is done by somebody else. So I think we need to give it a bit more thought to see how pragmatic we can be today to make the best use of what we have and solve really existing on-the-ground problems. And this structure will come out of that as an immediate step. In the long run, we can certainly go towards more and more, forward-thinking stuff.
Thanks, Raghu. I think it's nothing wrong in what you're saying, and there is no point creating a layer which is disconnected. We must move towards where it's a integrated system. We talk about integral wellness, and if we don't integrate our units, it doesn't make sense. However, I think this particular initiative was born out of two main constraints which FAMC was facing. One is that if there are new applicants, on what basis do they say yes or no? And then there is also a matter which is related to asset. Let's say I live in Kalpana and I want to start a practice within my apartment. Now, is that considered it's a partial service? I give one person every day free service and then I can call it a service, however remaining 10 I charge. So how do you bracket it? So there are so many, it's not black and white, there are a lot of grays. And it's the matter of gray which they are not able to understand. If it is black and white, they know how to say yes or no. So this is where the WCG comes into play. They gauge the grayness of the gray and recommend. So the onus is on the healthcare professionals to include more into the fold or not. So they can evolve over the period and they can see how much they can include in their ambit of serving and taking services. Because it's two-way. You need to also see, for example, if you are saying tomorrow that you are combining the Sante to Arka to Mahalakshmi as one campus, and tomorrow if there are 30 elderly people who need palliative care or convalescence, Mahalakshmi cannot take care of that. So, and it is also not possible to immediately build 20 units to serve them. And then we have this kind of dispersed care system where the person like Mechtilt goes from one community to another community to serve. It doesn't make sense. So the idea is, can we make it more in a way flexible? And let's say tomorrow there is more need and 50%, 20 more rooms in Arka is made available for our people rather than running it as a guest house. So when this is where it comes as a WCG's decision. If it is a common asset, they can take the decision to say tomorrow we stop the guest house of Arca and convert that into a space to serve our residents. However, you cannot do the same with say Quiet or Aurodent or I don't know, Danya is here, Verite. I don't know, is it possible to do that? So this is where it's a fine line. I think it's something which the WCG need to walk. Because if we take the decision right now to say include, or because including may also feel for the therapist and the people who are outside the services to look at it as a centralized form, as something they are trying to control, and then the lack of freedom. So we have tried to keep a system.
I get that. Let me ask you.
Yes.
Just for clarification, is it? No. Is it for example, is it a subcommittee of FAMC at resolving issues FAMC is facing? Obviously, it requires to be solved. I'm not saying it is. All the points you mentioned absolutely valid. So that's one step. There's a merit in that. Or are we? I'm trying to understand so that we can accordingly. Are we trying to solve the healthcare needs of the community and the problems faced with existing and potentially who are going to come into the sector, healthcare sector practitioners here? That's not exactly very clear. The arguments you're making, I buy all of that.
Good question.
It's primary, seems the former one.
Yeah.
The second one might require certainly somewhat, I'm not saying this is, in addition to this, something more.
Yeah.
So if you can address that, it's only mere suggestion, that'll be useful.
So the document or the exercise that we did, we tried to address the second part, try to be as wide as possible. However, the organization structure is mainly the first part. It's a little bit confusing, I hope it answers, that's how it is. The WCG is serving as a subcommittee of FAMC to solve the very practical needs. However, the scope is wide enough to really go as far as they can. Like he mentioned, it's as much bigger wire you have, you can take more source. Sorry. Yes, Paula.
Yeah, I wanted to thank people for bringing up the issues around how do we live this process, because there are so many things that are important to people right now and really excellent care that is being given right now. And so when I see this kind of structure, I go, this structure needs to be secondary to the practice. So the practice is the people who are skilled and trained and qualified and giving compassionate care to individual Auroville and adjacent people. In my case, for the maternity, well woman gynecology and breastfeeding support. It's a very specific thing, you think, yeah? You can see that circle of what Morningstar does. Morningstar has collaborative relationships, excellent collaborative relationships with 3 hospitals, Jitmer, PIMS, and East Coast, Nalam Clinic. We have those collaborative relationships through the individual working people of that team of Morningstar. If it can be supported, promoted, acknowledged, recognized, yes, but it's already existing, so it needs to be seen. Home visits, I've been to 2 homes today. Mothers, a woman getting ready to give birth, to prepare, how is her home? Is she prepared for the baby? Another mother, seeing her in her own home, newborn baby. Do we expect her to go to some central location? No. Home visits are integral to many aspects of healthcare and end-of-life care. Many people prefer to stay in their home if they can. So my vision of this is I want to be in a functioning administration that is not oppressive. I want to be in a functioning administration that recognizes for health and well-being of the provider, we need to be empowered to implement our ideas, our vision, our dedication independently. Really, in a lot of ways, to be a happy practitioner, you have to have control over your work environment. If I don't have control over my work environment as a midwife, I am not going to be happy. So I imagine other people feel that way, right? If a doctor went in and told any of our doctors, oh, I'm sorry, you can't do that there, now you have to go do that over here, they're not going to be happy. So however this gets implemented, it must come from that side of things. People need to be empowered, recognized for the good work that they're already doing, and then this infrastructure should support and continue it into the future, where we have young people wanting to join the health sector.
It seems like a nice observation. I have nothing to say apart from 2 things. One is that there is nothing in this document that dictates the micromanagement. If you do the house visits or not, there is no mentioning of it. So don't get, don't imagine such things, it's not coming. The second aspect is, are we here to facilitate the practice? Yeah, but the practice has to be aligned with the purpose. Otherwise, what's Auroville here? So when you practice, even this is what the WCG's job would be, to see each and every practice that comes as a new activity or even the old activity, to review it, to see how is it aligned with purpose of Auroville. Simple as that. Because without that, there is no glue holding us.
It's me. My name is Giovanni. Can I?
I can. Okay, let me give an example. I will not take the healthcare because it may be controversial. I can take the example of communication where I represent. Many communicators may hold freedom of speech as the important freedom that they need to communicate. However, being in Auroville, there are certain things that I communicate is perhaps not aligned with the purpose of Auroville. I need to reflect and I need to correct myself. Only the freedom to practice my profession is not enough. That's what I'm trying to say. Hope it makes sense. Make sense? I am on my path.
So my name is still Giovanni. Can I do my? Okay. First of all, thank you for the presentation. It was very clear, very complete. A suggestion for the future, hopefully you will do more of this presentation. If you share the document in advance, I could have had, because I had many thoughts and fears, I have to admit. But it's very vague what is written here, but so it's reassuring for the time being at least. So sharing the document in advance was a good practice we had as a community. I was a member of RAS, which has been for now put in a corner as group. We have new RAS member, but so we had this practice of sharing the document before, getting feedback, and the community was voting. Now we are not longer in this scenario, unfortunately, from my point of view. But so I agree with the silos situation is not good, and you want to centralize. But there is, again, from my point of view, a danger in centralization. Because then you have a group of people, now we have 9 persons, who are taking decisions for the whole. So I'll give you an example. I am right now in a new phase of my life where I'm dedicating most of my energy, not all, in yoga. So I guess yoga is included in this, because I see a lot of pictures of yoga, so I guess yoga is healing for me. The way I teach is a healing practice, okay. So there are yoga practices which are for me very dangerous, like Ashtanga yoga. I hate Ashtanga yoga. I think it can be dangerous for people to practice. But I don't want to prohibit Ashtanga yoga, no? For me, for those, some people, maybe Kapha people, very muscular, maybe it can be good. But generally, Ashtanga yoga is a dangerous, I don't know if there is a Ashtanga practitioner here, dangerous practice. So given the current situation, I foresee a future where this group, maybe you will be there, no? I think we heard that you want to apply. Some people, you or some other people, can decide that Ashtanga yoga is not good, which I would even agree. But I'm more for freedom, no? Freedom of speech, freedom of meeting, freedom of smoking cigarettes. Now is prohibited. I think it's like too many. We are going from a completely and too much freedom in a opposite, which is so it's not so much a question, more a comment. I hope it's okay as well. So nutrition is another example, no? So I used to be vegetarian, vegan, for many years. Now I eat sometimes, rarely, meat, rarely. But you might want to prohibit me because meat is cancerogen. No? Meat causes cancer, is clear. So are you going to say only, and this would be a good decision, but this is in your mind. I may ask Lakshay now, you think, I don't know if you're vegetarian, but you think you can go to the extent of saying, okay, now all litter is in Auroville, no meat anymore. And so on and so forth, no? Like, that's what I am a little bit concerned. I'm giving centralized power, and there is not so much individualization as someone was saying before.
Yeah. So Raghu, this is exactly what we were expecting. The more we try to bring everything under the ambit, there could be a fear of the centralization, that's why we consciously avoided it. So to answer your question, I'm not getting into WCG. Second part, this is only, like I said, for where this is almost like I answered him. It's subletting the job of FAMC. They're already doing this job. It's only that from now on it will be done in a more informed way. That's it. It's like almost adding a health professional, a doctor to a GP. That's it. No, one more doctor is added there. But they are anyway doing their work. So WCG will only assist them. I am a vegetarian for last 26 years, proudly. But that does not mean that my family cannot eat non-veg. They all eat non-veg. So I am not here to say or preach, like mother used to say, for all these kind of questions, if you have not gone beyond that. Simple as that. So we cannot be preaching or creating strictures that won't work. So I would again appeal to you to ask difficult questions. Feel free, like I said, I will answer frankly. If there are any such, I'm glad that you brought it up. If there are any doubts, it's not that we know it all also. There could be certain things. The idea of not sharing this document widely with the community is because we wanted to meet you first, have this conversation, then we will share it with you right away. Then you can comment on it. Before we finalize the document and send it to FAMC, which will subsequently send it to GB, we would harness all your ideas also. So right now, before this document was shared with all the health professionals. There was no limit to it. Tell me if I'm wrong. No? Everybody could comment on it. In fact, there were many who were outside the purview also who commented on it. But we didn't put it out in the open because I saw yesterday some document was being shared. It was a working document. We further worked on it, but it's not right to put a half-cooked thing and then it spreads fear, which is unnecessary. We will definitely share. Ask difficult questions, please. FAMC is here.
Yeah, I don't have a question, but I have to say, you have in the beginning said about the 5 aspects of life, the spiritual, physical, vital, mental, psychic, and spiritual. And Auroville, whether I accept it or not, it is the place where the consciousness works very strongly. And when the consciousness works, it also creates some issues in the body where there is a resistance, and that appear as illness or ailment or whatever. And we need to individually work on our own body with the consciousness. And right now I remember something when she says that the divine consciousness can repair the damages of the body.
Amen.
So all the healing practices, everything that will go, but at the same time we need to work on our, and whatever the external structure, healing, that is not all or everything. Something has to be done by each one of us because this place is like this.
Absolutely.
And if you are in your 9 members or whoever, some people who could recognize or direct, I don't know, this kind of healing, integral healing as you say, that would be good. And but whether there are not, we have to take our responsibility of growing in consciousness and working on our body. Thank you.
Valid point. Anybody else?
Any question? Thank you so much.
Any curveball? No? Okay. Thank you very much. Any last words? Yes, very important. Very healthy tea and integral samosa is there.
I just want to thank this team because they have done quite a big work. And I just want to see, even this has been initiated by FAMC, we have actually not tried to control it. We have participated, but I think these people, they have had their freedom to do as they wanted. I thank them a lot because they have done quite a lot of work. Thanks to Laksha, thanks to Auroville, thanks to Surya Kanti. Thank you.
Thank you for all. And again, I want to say something. This is the moment we need to work together, what Sonia said. And if you are not scared, away from that FAMC, whatever it is, then FAMC will do or OSD will do whatever they want. No, people are not trusting what I say. Since more than 6 months I am saying this to our health sector. Some of them, they are very scared and to join in this event, even to discuss with the meeting. Then we may lose our freedom. I am sorry to say, but we need to come together to work together. Thank you very much, everybody. Thank you.
Thank you. Thank you.
You want to say something?